This is Matthew Menendez with White Plume. I'm going to go ahead and get started. This webinar is designed for those of you who've already come to our ICD-10 Physician Productivity webinar. This webinar is going to be more detailed, more focused, specifically on AccelaCAPTURE, the electronic superbill designed for ICD-10. So I'm going to go through that. I'm going to walk through that for you today. Again, any questions that you have, feel free to use the questions panel. I'll answer as many of those that I can. Just a quick overview of our agenda today, what I hope to accomplish over the next 45 minutes. I'm going to give you an overview of AccelaCAPTURE. Again, that's the web-based electronic superbill that makes the ICD-10 process very, very easy for your doctors and make sure that you get the right billing information to your billing team the first time so that they can get the claims paid. So we're going to walk through and look at the appointment screen first. The appointment screen is kind of the home screen in AccelaCAPTURE. It gives you all of your patients for that day or a range of days. So it makes it easy to go through and capture that information. We're going to talk about how that works. We're going to talk about how you get your schedule into the appointment screen as well. Then we're going to go through and look at how to complete that electronic superbill in ICD-9. We're going to walk through that same example, do it in ICD-9, and then we're going to turn around and do that same example in ICD-10. The best practice for most organizations is to start using the electronic superbill in ICD-9 so that your providers, so that your staff can get used to working in the electronic superbill world before they have to turn around and start doing the same thing in ICD-10. That way you're only doing one change at a time. So we're going to walk through an encounter in ICD-9, we're going to walk through an encounter in ICD-10, and then I'm going to show you how to print the encounter charge data report. This is the report that the billing staff may print at the end of a morning clinic or at the end of the day or maybe the next morning or maybe at the end of the week so that they have all of the charge data that they need to print that encounter data into their billing system. This is the starting point for our web-based version of AccelaCAPTURE. Many of you may opt to upgrade to our more full version that has bidirectional HL7 interface capability with the target practice management or billing system to automate the data entry process. I'll make sure that I leave time for questions and answers at the end. So again, use the questions panel for any comments, any questions that you have as we go. Just a quick reminder, quick refresher for what we talked about last time, why we're talking about this. The problem is ICD-10. As we transition to ICD-10, physician productivity is at risk. This is a study that was done by the advisory board. They looked at Canada's transition to ICD-10 and saw a 10 to 20% decrease in physician productivity because they were answering questions from the coding and billing staff. I need you to be more specific here. Can you tell me more about the type of illness? Can you tell me more about the type of injury? And doctors were spending 45 to 90 minutes per doctor per day answering those types of coding questions. That is entirely unacceptable here in the United States under our fee-for-service model. Our doctors cannot afford to spend less time with patients, and it's unfair to ask them to spend less time with their families. Now the coder productivity, the rework productivity declines as well because ICD-10 is more complicated than ICD-9. You'll see coders, billers have a dip in their productivity the first year, but that'll come back up as they get up the learning curve. The problem is they never get back to those pre-existing levels because ICD-10 is harder than ICD-9. It's more complicated. And the rework productivity is on the AR side. Increase in inquiries, adjustments, denials coming from the payers is going to increase the amount of work the accounts receivable staff has to do to follow up on those claims. So we're trying to make this a smooth transition for the doctors, protect their productivity first and foremost, but also make sure that our revenue cycle teams have the data they need to get the claim paid correctly the first time. And the right place to start with that is by looking at the codes that you use today. We talked about ICD-10 conversion analysis, taking the diagnosis codes that are on your current superbill, your encounter form, your fee ticket, and converting those into ICD-10 codes. What you see from the results across every specialty is that the increase is significant, and that number of codes will not fit on an 8.5 by 11 inch piece of paper. Even though the paper superbill is a very productive tool for the provider, it cannot and will not work in ICD-10. Now, we further classify the ICD-10 conversion analysis into 3 risk categories: low risk, moderate risk, and high risk. I'll show you examples of each as we walk through the AccelaCAPTURE demo. Low risk codes are those that can be converted directly from ICD-9 into ICD-10. Depending on your specialty, that may be between 15 and 40% of your most commonly used codes that fit into that category. The moderate risk and the high risk codes cannot be converted one-to-one and require additional information in ICD-10. So I'll show you how that is handled in an easy way for the provider to make sure that they can give the billing team the coding information necessary to get the claim paid. Right? So I want to step through that application. What I'm going to do is I'm going to open up my web browser. So you should see my web browser on your screen. This is a web-based application. I'm using Chrome as my browser. You can use Chrome, you can use Firefox, you can use Internet Explorer, you can use Safari. Any web-enabled device is able to access AccelaCAPTURE. It's a web-based application. Think of it like online banking. As long as you know the URL, as long as you know your username and password, you can have secure access to your information from any web-enabled device. So that means laptops, desktops, Macs, Androids, iPads. I would not recommend a mobile device because keep in mind what we're trying to replicate is the paper encounter form, the paper superbill on your screen. And it's difficult to replicate an 8.5 by 11 inch piece of paper on a small 4-inch iPhone or Android mobile phone. Right? So what I do is I'm using Chrome to access this application. If you are using Internet Explorer today, you might want to consider using Chrome or Firefox as they tend to perform a little bit faster than Internet Explorer. So what I'm going to do is I'm going to type in my username and password, and I'm going to log into the application. Now what you'll see, the first screen that it brings me to is my appointment list. I'm wearing my provider hat right now, and I'm logged in as Dr. Carlton. And so what you'll see is I'm viewing the list of patients scheduled for Dr. Tony Carlton at the Sharondale location for today, May 21st. Now I can certainly change away from those defaults. If I need to see yesterday's encounters or all of the appointments for this week, I can do that. If I need to view multiple providers or multiple locations, I can do that. That is a user-by-user setting. You may have nurses or PAs who work across multiple providers, and they want to change to not just see Dr. Carlton's, but they also want to see Dr. Bishop's patients as well. Again, they can make that change as necessary. I've got mine sorted by the appointment time because I think that makes the most sense. My earliest scheduled appointments are on top, the later ones are on bottom. All right? Now, let me say one thing about how I got appointments onto this list. There are 3 ways patients can get onto my appointment list. You can use any combination of these. They are not mutually exclusive. Number 1, I can use an HL7 interface from my appointment or scheduling system to get the appointment data onto my list. Number 2, I can upload a CSV file, which is basically an Excel file of my patient appointments to populate this list. Number 3, I can have staff actually key in this information to populate this list for my providers. The point is we want to make sure we make this easy for our doctors so that they see their patients on their appointment list. So I'm wearing my provider hat. I'm ready to see patient Lightning McQueen. You can see that that encounter is already in progress. When I click on anywhere on that orange row, if I click on the patient's name, if I click on progress, you'll see the electronic superbill for Lightning McQueen pops up on my screen. We customize each of these electronic superbills to make sure they look as close to possible as the paper superbill that they're using today. That makes my training process for my providers easier. It minimizes the change for my clinical staff. And it protects their muscle memory, which is what makes the paper superbill so fast, so productive for my physicians. So I'm going to go through and do this encounter in ICD-9, and then we'll do the exact same encounter this time in ICD-10. All right. So to select my CPT codes, I'm just going to click, and you'll see that it highlights yellow. So I've got a level 3 office visit. I've got a cholesterol test. I flip over to the back side. I have my diagnosis listed here. So what I'm going to do is I'm going to pick 3 diagnoses. I'm going to pick cough. Then I'm going to scroll down on my encounter form. I'm going to pick carpal tunnel syndrome. And then I'm going to select congestive heart failure. 1, 2, 3. I'm going click, click, click instead of circle, circle, circle like I did on my paper encounter form. Not much change there. When I'm finished, I'm just going to say save and close, or I could say save and complete if I was finished with the encounter. It brings me back to my appointment screen and lets me know that the encounter for Lightning McQueen has been saved. Again, if we can train them to do this in ICD-9, it's going to make the conversion to ICD-10 much easier. So let's go back and do that exact same encounter, this time in ICD-10. I'm going to click on Buzz Lightyear, and you'll see his electronic superbill pops up on my screen as well. Again, think of it this way. Pretend that it is now Thursday, October 1st. It's the first day I have to start using ICD-10. And I want you to imagine that I'm one of your providers. I haven't come to any of the training sessions on ICD-10. I'm seeing my first patient, and let's see how I do. The front side stays the same. There are no changes to CPT codes. Make my selections, flip over to the back side, I'm done. This is the magic of what you can do with an electronic superbill. The back side looks the same. I haven't listed out 800 or 1,000 or 6,000 ICD-10 codes. It still looks exactly the way that it did the day before. Nothing's changed. That's the magic of what you can do with an electronic superbill. So I'm going to come down here, and I'm going to click on cough. And what you're going to notice is it converted that into an ICD-10 code for me automatically. It highlighted it in green instead of yellow. That's a visual cue to me as the user to know that something is different. I love those. Those are really easy. I wish everything were that easy in ICD-10. Unfortunately, it's not. So let's look at a more complicated example. Let's look at one of the moderate risk examples. So I'm going to go down and scroll down and do that exact same diagnosis that we did before, carpal tunnel. And when I click on this, what you'll see is it cannot convert that for me automatically. So what it does is it gives me a pop-up. It shows me my choices in ICD-10. It's got a choice for left arm. It's got a choice for right arm. Now, it also has a choice for an unspecified arm. That is a valid ICD-10 code. Most practices don't want to use that code. Unspecified codes are very dangerous in ICD-10. They're valid codes, but there's a risk that those codes will cause the claim to get denied. Most of our clients are choosing not to show their providers the choices for unspecified laterality like that. Now, coding is part art and part science. There are places where reasonable people can disagree. But most clients are choosing just to show the options for left and right. Let's say it's in the right arm. I'm going to make one extra click. What you'll see is it highlights that selection. It closes the window for me, brings me back to my electronic superbill, and you can see it's put in the new code and the new description for me. Right? Again, trying to make this process very, very easy for your providers. So let's look at a more complex example like congestive heart failure. When I click on this, again, you'll see it cannot convert that for me automatically. And it displays my 15 choices, but it's organized it in a way that doesn't require me to read through a list of 15 diagnosis descriptions, trying to decipher one description from another. We've organized the new documentation requirements for ICD-10 into 2 dimensions because there are 2 additional documentation requirements for congestive heart failure in ICD-10. On the vertical axis, you can see we have put the onset, so acute or chronic or acute on chronic. And then on the horizontal axis, you have the type of heart failure. Is it systolic congestive heart failure? Is it diastolic congestive heart failure? Is it combined congestive heart failure? So that very quickly I can see the new documentation concepts and I can make a selection at the proper intersection. So if I've got a patient with systolic chronic congestive heart failure, I've got one additional click to select the right ICD-10 code. It closes the window for me, brings me back onto my ticket, and you can see that it's put in the correct ICD-10 code and description. Now let me make one more comment here, because a lot of doctors are still dictating their note. It's again, it's the fastest thing for them. And they want to use that paper encounter form as a reminder for who they saw, what they did. Some of our clients, if they're dictating immediately, will use this summary screen to show them who they saw, what they did. Others will have staff that print this out for them so that they can view it at the end of the day when they're going back and doing their dictation. But what you'll notice, it's got the ICD-10 description in here, so it shows me where I need to be more specific in my dictated note. So instead of just saying CHF, it reminds me to say chronic systolic congestive heart failure. Now this screen is simply a summary screen, shows me everything that's been selected. If I want to reprioritize a diagnosis code, maybe move that CHF up to the primary diagnosis, I can do that. If I want to link a particular diagnosis to a particular CPT code, I can do that as well. If a provider doesn't do this, somebody wants to do it behind him, that's fine. If the provider doesn't want to do this and wants the charge entry staff to do this, that's fine as well. I do have a section where I can type in notes, things that are specific, things that I used to write in on the paper. I want to be able to write that in. I can do that as well. When I'm finished the encounter, I can click on Save and Complete. Again, it closes that window for me, and you'll note that it dropped that patient off my list. Again, as Dr. Carlton, I don't want to view the completed encounters. I only want to see on my list the ones that still need to be seen. Now again, that's a configuration setting. It's a user preference. If I want to change that view to say, yes, please do show me the completed encounters, I can do that as well. All right? So I've got control over that. It's about how I want to handle that workflow. If I need to go back in and complete the encounter for Lightning McQueen, all I do is click on his name. You'll see the encounter comes up. I can view the information on the summary screen again. If I wanted to do that, if I wanted to come in and make a change, make an update, I can do that. Again, save and complete the encounter. You'll see that on my screen. It's changed that status. It's changed the background color. You've got control as the client over what statuses you use, what you want to call them, what colors you want to use. That's all customizable within the application. I can also change the encounter status without going into the ticket by using the action button on the far right. So what I've tried to show you so far is how the appointments get onto the appointment list, the three methods there, HL7, CSV, manual entry by clerical staff. Showing you an encounter in ICD-9, how we design the electronic superbill to look just like the paper superbill. Instead of circle, 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 they go click, click, click. How that same encounter is done in ICD-10. The low risk ICD-9 codes can be converted automatically. The moderate risk will show you a pop-up with those choices. The high risk will show you the pop-up with those choices so that the doctor only has one extra click to select the right code with minimal training required for the physician so that the billing staff has access to the information that they need. So let me switch hats and let me be one of your billing employees for just a moment. Let's say it's at the end of the day or the end of clinic, and I want to print out that report so that we can do our data entry. Up at the top, I'm going to go to Reports, and I'm going to click on Encounter Charge Data Report, and that brings me to a screen that lets me decide which encounters do I want to put on this report? Do I want that to be for all providers or just a single provider? All locations or just a single location? I can multi-select there as well. So I'm going to say I want to do all providers at the Sharondale location, only the ones that are completed. I don't want to take the ones that aren't quite done yet, right, for today. I set my criteria, I hit refresh, and at the bottom of the screen, I'll see all the encounters that meet that criteria, those 2 encounters that we just did. So I'm going to create the report in Excel, and what you'll see is it downloads in the bottom left-hand corner of my screen. It creates an Excel file on my machine so that I can then open that report, and what you'll see is I'll get that encounter data. I'll get the patient information, the date of birth, patient ID, the location, the date of service, who the provider was. Then I'll also get the encounter data with the CPT codes and the correct units and any modifiers that were entered with the diagnosis codes that were associated with each line item, so that I have all the information here that I need to key the charge data into my practice management system, so I can run my missing ticket reports, so that I can file my claims, so that I can make sure that we're getting paid correctly in the new world of ICD-10. I know that I went through a lot of information. I know that I did that quickly. Remember what we're trying to do. We're trying to protect the doctor's productivity. We're trying to protect the revenue cycle efficiency as we transition to ICD-10. We went through the appointment screen. We went through the Superbill in ICD-9. We went through that same encounter in ICD-10, and then showed you how the billing staff can print that report so they have all the information that they need for data entry at the end of the day, or at the end of the clinic, or at the end of the week, depending on how you do that today. We try to make the tool flexible so that it can accommodate your existing workflow. So if you have other people in the office who touch the paper Superbill, they're probably going to need to access the electronic Superbill also, whether that's a front desk employee or a nurse or somebody in the lab. We try to make that flexible, so when you're thinking about your workflow, we want to make sure we accommodate that with the electronic Superbill as well. All right, I know I went through a lot of information and I did that quickly. I'll put my contact information up just in case anybody needs that or has any follow-up questions after the webinar. But let me do this. I'm going to go ahead and open it up and try to answer any of the questions that came in through the questions panel.